So I've been really trying to find out which topic I would actually do for my 300th video on YouTube. I found a comment that said, why don't you do ectopic pregnancy? So I decided to do a video on ectopic pregnancy. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at ectopic pregnancy. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab your piece of paper and your pen and let's go. So here's a warm-up question. Ectopic pregnancy A has a higher incidence in women with copper intrauterine contraceptive devices. B cannot be diagnosed by ultrasound. C is treated by laparoscopic salpingostomy. D is excluded by a negative serum beta-HCG. E has a recurrence rate of 15% after conservative therapy. This is a true or false question. You may pause the video, write down your answers. I will give you the answers at the end of the lecture. So what exactly is an ectopic pregnancy? So if you're ectopic, it means you're somewhere where you don't need to be. So this is just simply implantation of the conceptus outside the normal confinements of the uterine cavity. So this can happen in the fallopian tube, it can happen in the ovaries, it can happen in the cervix, it can happen in the abdominal cavity or peritoneum. Sometimes you may get a pregnancy embedding itself within the uterine cavity, then you get another pregnancy outside the uterine cavity. You call that as a heterotopic pregnancy. These are quite uncommon, but they do happen in a few selected cases. In about 95 to 98%, most of these are going to be occurring in the fallopian tube. Remember that the fallopian tube has predominantly four parts: the fimbriae, the isthmus, the infundibula, and the ampulla. So there is a mnemonic that goes like FIFO is in action. F for fimbriae, IS for isthmus, IN for infundibulum, and AC for action. Remember that most of the ectopic pregnancies, over 50% of them, are going to be situated in the distal ampulla. And 20% of them will be found in the isthmus, 12% will be found in the fimbriae, 10% will be found in the interstitial part. And you may get other locations such as the cervix, such as the ovaries, the cornu, and the abdomen. Remember that the cornu pregnancies, which are a part of the intramural portion of the fallopian tube, these are the most dangerous because the space is very small and there is an increased risk of uterine rupture with this type of ectopic pregnancies. And you get a few rare cases where the ectopic pregnancy is actually found in the peritoneal cavity, and some cases of these have actually been carried up to the third trimester. Now remember that a ruptured ectopic pregnancy is going to lead to bleeding and it's going to lead to death. So this is actually one of the leading causes of pregnancy-related maternal death during the first trimester. So it means that the diagnosis and the treatment of this condition actually before rupture is going to decrease the risk of death in these patients. Now remember that about half of these ectopic pregnancies are idiopathic, so you're not going to even isolate a cause to these ectopic pregnancies. And trophoblastic invasion of the tubal wall can actually cause tubal rupture and potential major hemorrhage. However, most of these cases are going to be resolving spontaneously. And like I told you earlier on, you may have an heterotopic ectopic pregnancy where you have a pregnancy that is found within the uterine cavity and another one that's found outside the uterine cavity, though the incidence in the population is low, about 1 to 25,000 to about 30,000 cases. And the incidence actually significantly increases, especially in patients that are undergoing in vitro fertilization treatment. That's in about 1% of these cases. Risk factors include a previous history of ectopic pregnancy, which is the biggest risk factor. Remember, in obstetrics and gynecology, if you've had the condition before, you are at risk of having the condition again because you may have certain risk factors that predisposed you before. You may also have pelvic inflammatory disease such as gonorrhea, chlamydia, History of sexually transmitted infections, these are major risk factors because as you get this infection, it causes this scarring, it causes these adhesions in the fallopian tube that can block the movement of the ovum. Remember that the movement of the ovum is dependent on the fallopian tube. It's dependent on the cilia that you find in the fallopian tube. So if these are affected and there are some constricting bands or adhesions, these can prevent the movement of the ovum such that the sperm reaches that area, fertilizes it, and causes implantation in that area. Then the number of sexual partners, a family history of ectopic pregnancy, the use of intrauterine devices. These can cause tubal scarring and adhesions, which can cause obstruction. You can have a history of previous obstetric, pelvic, or tubal surgeries, also causing scarring. Increasing maternal age beyond the age of 35, which is very common with most of the obstetric conditions. Prior induced abortions, cigarette smoking for some reason, and congenital malformations of the uterus, such as the septate uterus. You may also have subfertility or assisted reproduction technology, such as ovulation-inducing drugs and in vitro fertilization, as well as in utero diethylstilbestrol exposure. Now, what exactly is the pathophysiology behind ectopic pregnancy? Remember that the ovum and the sperm are going to be moving in different mechanisms. The ovum is going to be moving by way of the fallopian tube, which possesses cilia which beat rhythmically to push the ovum towards the uterine cavity, whilst the sperm can actually move on their own using their flagella, and they're going to be ascending up the cervix. Through the cervix, they're going to be ascending up the uterus into the fallopian tube, where there's actually fertilization is going to happen. And remember that 3 or 4 days after fertilization, this fertilized ovum is actually going to implant within the uterine cavity. So it means that this implantation will occur at the appropriate time wherever the zygote happens to be at that particular stage. And anything that is going to be mechanically or even functionally preventing or interfering with the passage of this fertilized egg to the uterine cavity is actually going to result in an ectopic pregnancy. So it's actually believed that the main cause of the tubal implantation of this gestational sac is actually a low-grade infection. In about 50% of the women that have been operated on with ectopic pregnancy, there is some evidence of chronic pelvic inflammatory disease. So you get these products of conception that are going to be persisting for quite a considerable amount of time within the tube as one of the form of what we call a chronic ectopic pregnancy, or sometimes they gradually do get absorbed. So if the implantation site actually occurs at a site in the tube where there's not so much space for placentation to happen, then the process is actually going to be similar. Actually, where there is a lot of space rather for implantation to happen, the process is actually going to be quite similar to that of an intrauterine pregnancy. So this conceptus is actually going to penetrate through the tubes, it's going to penetrate through the mucosa, then eventually it's going to embed into the walls of the tube. So remember that this extravenous tissue from the trophoblast will actually penetrate through the entire thickness of the muscle layer of the tube. Eventually it's going to reach the serosa and the tubal-ovarian circulation. Because remember that the whole goal of the placenta is to form this fetal-maternal unit that is going to be essential for the exchange of oxygen and waste materials as well as nutrients between the mother and the child. So these trophoblastic tissue are going to be invading into the wall normally of the uterus in search of those spiral arteries. The same thing is happening when you have this implantation that's happening in the fallopian tubes. So remember that the fallopian tubes are not really distensible and they're limited, so this can actually result in rupture of the tubes. Though this event is usually accompanied by the death of the fetus, sometimes the rupture of the fetus is actually can result in sufficient attachment to the blood vessel supply such that it will still maintain its viability, and you get what is known as a secondary abdominal pregnancy that may sometimes, even in some cases, be carried to term. In an ectopic pregnancy, the uterine endometrium actually is going to be responding to the normal changes of the hormones in the body, so it undergoes the focal-decidual changes, which is the area stellar reaction. And if you get this ectopic pregnancy that is going to miscarry, the uterine decidua is also going to slough off as a cast, but more commonly as fragments that are mixed with small blood clots. So here's a pictorial picture. So as you can see here, you have this slowly leaking, resealing and rebleeding eventually is going to be happening, and then there's going to be some rupture. You may have some pelvic collection of blood that may be absorbed or sometimes may become infected. Then of course you get this massive intraperitoneal bleeding when it collapses, and then of course you're going to get the secondary abdominal implantation. If there's rupture that happens, you may sometimes have the broad ligament bleeding that's going to be contained as a unilateral bleeding, which is going to cause pain. Sometimes you may get this heavy vaginal bleeding. So the tubal pregnancy may actually terminate in 4 main ways. Number 1, it may be absorbed. So in a few cases, it's going to be possible that absorption is going to happen very early in the tubal pregnancy, and the embryo is actually going to die in the tube with small amounts of bleeding, and it will partly be absorbed. The second thing is that it can result in a tubal abortion, where part of it or all the products of conceptus are actually going to be expelled from the tube into the peritoneal cavity. The third possibility is that you may have a tubal rupture, which is actually the most dramatic and best known way of termination of the tubal ectopic pregnancies, and though in fact is less common than absorption or tubal abortion, there is actually some acute intraperitoneal hemorrhage that's going to be resulting from erosion of an artery. And remember that this pregnancy is often implanted in the narrow isthmus of the tube, so they carry the risk of rupture. And then you may sometimes have a secondary abdominal pregnancy, which is the rarest outcome of the 4, and here the embryo is going to be expelled from the tube and into the peritoneal cavity, and there's going to be this secondary attachment, and eventually this can sometimes be carried to a full-term abdominal pregnancy. What are some of the clinical features that we see? So compared to other forms of the early pregnancy disorders, there is actually no pathognomic sign, so you have to have a high index of suspicion to pick out an ectopic pregnancy. What we actually say is that any woman of reproductive age that presents to the hospital is deemed pregnant until proven otherwise. So the presentation may actually be sudden or gradual, but classically, though you get a rare presentation, is you may see that they get this acute presentation where they collapse in a previously very well young woman, and of course they have a period of amenorrhea where they're not attending their periods. Then of course they have this brownish vaginal discharge. Whenever you see this history of fainting, the history of amenorrhea, the history of this brown vaginal discharge, sometimes there may even be some abdominal pains, then you should think of ectopic pregnancy. Do a Gravindex test. If you do a Gravindex test and you find out it's positive, you order for an ultrasound and you realize that the uterine cavity is empty, then most likely this person has an ectopic pregnancy. And remember that the patient is likely to be shocked and requiring resuscitation in some cases, and they will give you a history of fainting, or sometimes they give you a history of this shoulder tip pain. Remember, this means that there's blood in the peritoneal cavity, irritating the diaphragm. That's going to be causing referred pain to the tip of the shoulder. Then you may get this acute abdominal pain. Then when you do an abdominal palpation, there's going to be a rigid abdomen, and this should be an indication that you should carry out an immediate laparotomy because you want to control the hemorrhage. Sometimes they may get this hemoperitoneum, like I told you, where you have this rupture of the fallopian tube, and this is going to be causing pain that's going to be in, or rather free blood that's going to be in the abdominal cavity, that's going to be causing diaphragmatic irritation, and this is going to be referred to the tip of the shoulder. You may sometimes get a subacute presentation, which is much more common, and here the diagnosis needs a very high index of suspicion. You get this low abdominal pains, which may sometimes be centralized, sometimes they may be localized to the side where the ectopic pregnancy is. You get this period of amenorrhea, which is usually about 6 to 8 weeks, because by 6 to 8 weeks, this product of conceptus should have grown to a significant amount such that it can't grow any further than this. Growing any further than this will result in rupture. So you get this history of this 6 to 8 week history of amenorrhea, and you get this history of this patient trying to conceive or not using contraception, and then they may have this frank red vaginal bleeding, but most commonly they have this brown vaginal discharge. Then of course this vaginal bleeding occurs as the decidua is sloughing off after the demise of the fetus. Some patients may actually be even asymptomatic, and that's why I said you need a high index of suspicion. The classic triad for an unruptured ectopic pregnancy includes a period of secondary amenorrhea. Remember, this is lack of menstrual periods, so the patient will not be able to remember their last menstrual period. Usually it's about 6 to 8 weeks, though in 30% they present as a missed period. The second thing is you have vaginal bleeding, which may be in small amounts. It may sometimes be dark, which is old blood, or fresh blood, which can occur with or without rupture of the ectopic pregnancy, or sometimes associated with abdominal pain. Then the third thing in the classical triad is the unilateral pain, which is often this abdominal pain which persists on the side where the ectopic pregnancy is implanted. So this pain is going to be constant. It's going to be unilateral because you get the spasms of the tubal muscles. And of course, sometimes it may be referred to the shoulder via the phrenic nerve from the blood that you find in the abdominal cavity that is irritating the diaphragm. And as the ectopic pregnancy ruptures, you get these symptoms that vary depending on the extent of the bleeding into the peritoneum, depending on the extent of the irritation. But you may generally have hypotension, you may have tachycardia, and then when you perform an abdominal examination, you may have rebound tenderness, you may also have guarding. So when you examine this woman who has a suspected ectopic pregnancy, you want to record the pulse and the blood pressure. Remember, they may be hypotensive, they may be tachycardic. Sometimes the pulse may not even be perceptible. When you examine the patient, you may also get that they shoulder pain that is secondary to irritation of the diaphragm via the phrenic nerve. You may get this vascular instability, low blood pressures, fainting, dizzy episodes, and even a rapid heart rate. These symptoms are present in about 95% of the cases and are the most typical in patients with ectopic pregnancies that have ruptured, so those that are bleeding within the peritoneum. When you perform a gynecological examination, you must do this prior to a pelvic examination. So if there is an ectopic pregnancy that is expected, then you must put an IV line, as it can rupture at any time and you need to resuscitate this patient during the examination. So make sure that you have your two large bore cannulae that are inserted in this patient. So the pelvic examination is going to be revealing either a normal or a slightly enlarged uterus. Then you do perform a speculum or bimanual examination, which is in an environment where you can actually resuscitate this patient, because this patient can begin to bleed at any time and you can actually even provoke the rupture of the tube. Then, of course, an unruptured ectopic pregnancy may show you cervical motion tenderness, which may also be seen in PID, adnexal tenderness. You may also have uterine enlargement and fever, which are usually absent. Then you may get some investigative findings which get to be positive, like your beta HCG, which is positive. And when you do an ultrasound, this may or may not even review an adnexal mass with no significant intrauterine pregnancy that will be seen on the scan. What's our differential diagnosis? It could be a spontaneous abortion, whether a threatened, inevitable, or incomplete. An ectopic pregnancy itself, obviously, because that's what we're discussing. Ovarian torsion, a pelvic inflammatory disease, acute appendicitis, which is a pelvic, acute salpingitis, a high-detectable mole, ruptured ovarian cyst, degenerating uterine fibroids, benign or even malignant lesions such as a choriocarcinoma or cervical cancer, trauma. What investigations do you want to do? So remember, you want to do a pregnancy test for this woman. You want to confirm the pregnancy. So a urine pregnancy test is going to be positive and the beta HCG levels will be greater than 25 milli-international units per mil. And this is approximately 1 week after conception. Then you want to do a quantitative serum beta HCG. Remember that if the quantitative serum beta HCG are falling, this is going to be suggestive of a miscarriage, while as the slowly rising values that are seen in less than 60% of the cases in 48 hours are going to be suggesting an ectopic pregnancy and should be reviewed 24 hours later. But in an ectopic pregnancy, the beta HCG should increase by at least 65% every 48 hours in the first 6 to 7 weeks of gestation after day 9. Then the value of serial beta HCG is actually, in a stable, reliable patient, can actually be followed up with serial beta HCG levels, and this inadequate rise in the beta HCG is going to be suggestive of an ectopic pregnancy or a non-viable pregnancy. Remember that beta HCG levels are not, and I repeat, they are not going to be correlating to the size of ectopic pregnancy. They don't correlate to the potential of rupture. They don't correlate to the location of the ectopic pregnancy, and they don't correlate to the gestational age of the ectopic pregnancy. You also want to do an ultrasound, preferably a transvaginal as opposed to you doing a transabdominal. This is going to help you assess the location of the ectopic pregnancy, the fetal viability, as well as the contents of the uterus. In most of our cases, we often do transabdominal ultrasounds in our setup. And of course, this is going to be suspected if you look at the uterine cavity and the gestational sac is not present within the uterine cavity. So it'll be in the background that someone comes in with those classical symptoms. You send them for a beta HCG test, it's positive, and then you send them for an ultrasound and you don't visualize a gestational sac in the uterus, then you should suspect that there is an ultrasound. Remember that the threshold for detecting an intrauterine pregnancy on the transvaginal ultrasound is, and the beta HCG level is going to be roughly around 1,200 milli-international units per mil. So the features that are going to be suggestive of an ectopic pregnancy on ultrasound are going to be, number one, an absence of an intrauterine gestational sac. So this is the most suggestive feature that we see on the ultrasound. Next on mass, you may get fluid in the cul-de-sac. Remember that this fluid is in the dependent portion of the pelvis. This can actually represent blood from the ruptured ectopic pregnancy. You may also have multiple echo masses that you see in the region of the tube. Then you may get thickening of the endometrium for the implantation of the fertilized ovum. This may lead to the ultrasound actually showing you what is known as a pseudo sac, which should be distinguished from a normal gestational sac. So remember that an HCG discriminatory zone is described where you have a titer between 1,000 to 1,500 international units per mil, which is associated with the presence of an intrauterine sac on your transvaginal ultrasound, or if you get a level of 6,000 to 6,500 international units per liter for a trans-abdominal scan. So this is going to help you increase the accuracy of diagnosis. Sometimes if there is no viable intrauterine pregnancy or ectopic embryo, that can be visualized on the transvaginal ultrasound in the presence of a positive pregnancy test, then you call this as an ectopic pregnancy of unknown location. Remember that the diagnosis of an unruptured ectopic pregnancy results rest on the results of the quantitative serum beta HCG titers combined with your vaginal sonography, that's your vaginal ultrasound. Then of course it's going to be based on the assumption that when you have a normal intrauterine pregnancy that has progressed to where it can be seen on the vaginal sonogram at 5 weeks gestation, the serum beta HCG titers is going to exceed 1,500 milli-international units. With the lower resolution abdominal ultrasound and an intrauterine pregnancy will not consistently be seen until 6 weeks. So the beta HCG discriminatory threshold for this abdominal ultrasound can actually detect an intrauterine gestation of a beta HCG level of 6,500 milli-international units compared to the 1,500 milli-international units. Therefore, the failure to see the normal intrauterine gestational sac when the serum beta HCG levels are greater than 1,500 is quite highly suggestive of an ectopic pregnancy. So other investigations, you may do a cholecystectomy and a paracentesis if you're suspecting that this ectopic pregnancy is ruptured. Do a full blood count and a cross match because you want to determine the blood type and the Rh factor. Remember that if this woman is rhesus negative and she's married to a rhesus positive person, then they have to actually get anti-D immunoglobulins. That's your ROGAM to prevent them from being sensitized and therefore preventing a condition that's known as erythroblastosis fetalis. So this is done for all pregnant women that come in with vaginal bleeding, those that are rhesus negative, those that have Rh antibody screening negative, and this is done to prevent maternal isoimmunization. So which is this generation of these antibodies against fetal red blood cells in the current and even in future pregnancies. You can also check for the levels of progesterone, but the result is not usually available just immediately. Levels that are greater than 25 nanograms per mil are suggestive of a normal intrauterine pregnancy. Those that are less than 5 nanograms per mil are suggestive of an abnormal pregnancy. So with this may either be an ectopic or a non-viable pregnancy. Then those that are between 5 to 25 nanograms per mil, these are unclear, and unfortunately many results are going to be falling in this range of 5 to 25, and of course this is not really so helpful. What are our management principles of a patient that comes in with ectopic pregnancy? Number one, we want to determine if the patient is hemodynamically stable. The second thing is we want to determine if the ectopic pregnancy has ruptured or it hasn't. Number three, we want to administer anti-D antibodies. If the patient is rhesus negative, then number four, we want to determine the best method of treating this patient, whether it's going to be a medical treatment or it's going to be a surgical treatment. So the first thing, remember this is an emergency. The first thing that they come in is you want to do your ABCs. So you want to ensure that the airway is patent. You want to ensure this patient is breathing. You want to administer your oxygen. And you want to give them your IV access with 2 large bore cannulae, ideally 16G. If they're in shock, then you start resuscitation with IV fluids. You get bloods and you send for blood transfusion whilst you are organizing for the emergency laparotomy. If they're not in shock, and if the ectopic pregnancy is ruptured, then you want to perform an emergency laparotomy, possibly with a blood transfusion. If it hasn't ruptured, then you want to perform an urgent laparoscopy or a laparotomy. In our case, laparoscopy are only done by a few individuals, so by the time that individual is actually available, the patient may have even died. So most likely you want to perform a laparotomy in most of the cases, but we do perform laparoscopic operations in our case here, even in Zambia. Then, if the patient is hemodynamically stable, they're reliable, meaning that they can come back to the hospital for follow-up, they're compliant to the medication that you're going to be giving them, and the ectopic pregnancy is less than 3.5 centimeters, and there is no evidence of rupture, there is no evidence of significant bleeding, then we can actually consider managing them conservatively. And remember, this must be reviewed with your unit consultant. And you, as a junior doctor, cannot make this decision. You must review this with your consultant. The patient must follow this strict criteria. They must be hemodynamically stable. They must be reliable and compliant, meaning they'll take the medication and they'll come back for review. And the ectopic pregnancy must be less than 3.5 centimeters. And of course, there should be no evidence of rupture or significant bleeding. It's very rare in our setup here that we manage patients conservatively because most of them don't really come back for review. So for all patients with suspected ectopic pregnancy in our setup, we just use the surgical treatment. So the patient must actually be able to comply with these multiple visits that we'll give them. If there are any concerns for loss to follow-up, then the patient is not a candidate for medical treatment. They must be hospitalized. Methotrexate is what we're going to commonly use to give, and we're going to give this as an intravascular injection, but some oral formulations are actually available and quite effective. And local injection of methotrexate has been associated with higher treatment rate success than systemic injection of methotrexate. There is a significant difference, but with similar rates of subsequent intrauterine pregnancy or repeated ectopic pregnancies in the future. So the beta HCG level should be monitored weekly to make sure that there is resolution of the pregnancy, and for those that are Rh negative, we must give them RhoGAM. So medical management is going to be using methotrexate. Remember, methotrexate is an antimetabolite which is going to be inhibiting an enzyme that's known as dihydrofolic acid reductase. This is eventually going to interfere with DNA synthesis. So this means that this methotrexate is going to be attacking those tissues that are rapidly proliferating, and this is going to include trophoblastic villi. So the dose is going to be calculated based on the patient's body surface area and is about 50 milligrams per square meter. So this indications of this medical use, they must fill all these criteria. Number one, it must be an early ectopic pregnancy that hasn't ruptured. Number two, the patient must be hemodynamically stable. Number three, the ectopic pregnancy must be less than 3.5 centimeters. Number four, the beta HCG must be less than 1,000 international units per liter. Sometimes we may consider between 1,500 to 5,000. There should be no history of folic acid supplementation. They should have no heartbeat when you do the ultrasound. No cardiac activity that's noted on the ultrasound in the gestational sac, wherever you find it. The patient must be compliant for the follow-up. Then, of course, the intrauterine pregnancy must have been ruled out. So what are some of the contraindications? So you have some relative contraindications if you do find some fetal cardiac activity with the ectopic pregnancy, if the levels of quantitative beta HCG are greater than 15,000 milli international units per mil, or if the ectopic pregnancy is greater than 3.5 centimeters. Those are relative contraindications. But absolute contraindications where you cannot give methotrexate, if a patient is hemodynamically stable, remember methotrexate will take some time to work. Number two, if they have leukopenia, which is a low white blood cell count, remember methotrexate is going to further suppress the immune system. If they have thrombocytopenia, platelets less than 100,000 cells, then you don't want to give them methotrexate. If they have active renal or hepatic disease, active peptic ulcer disease, if they have possibility of the concurrent viable intrauterine pregnancy, or if there's a presence of a ruptured ectopic pregnancy, or if they are breastfeeding, methotrexate is absolutely contraindicated. Side effects include nausea, vomiting, stomatitis, conjunctivitis, gastrointestinal upset, photosensitive skin reactions, and in about 2/3 of the patient, they may get this non-specific abdominal pain. Remember that the advice to women is to avoid sexual intercourse during the treatment because it takes some form of contraception so they should take some form of contraception for about 3 months after methotrexate treatment, and they should avoid alcohol and exposure to sunlight during the treatment. Remember that methotrexate should never be combined with NSAIDs because this potentially can cause renal damage. Surgical management is what we do for most of our patients, and the indications for surgery are going to be patients that are unstable, patients with significant pain, patients that are bleeding, and those that have contraindication to methotrexate use. So we can perform laparotomy for For those that are hemodynamically unstable, for a laparoscopic examination and treatment, we can enter into the peritoneal cavity via this large incision that's made on the abdominal wall. Remember, this patient will already have 2 large bore cannulae that are needed for administration of normal saline, as well as for the type and crossing for the blood. This is actually fast to access the abdominal cavity and needs minimal equipment. On the other end of the spectrum, we can perform a laparoscopic examination, which can both be diagnostic and therapeutic. So this is used for patients that are hemodynamically stable, and we enter into the abdominal cavity via a small incision. It's like a keyhole incision, and we can actually visualize the abdominal pelvic organs using a small camera. So remember, this can be diagnostic, only to visualize, or it can be therapeutic or operative to perform certain surgical procedures. Of course, it needs carbon dioxide, so if there's a shortage of carbon dioxide, it becomes very difficult to do this laparoscopic examination. So it has less bleeding, a shorter operating time, there's less analgesia that is required, and of course the hospital stay is shortened and has a shorter convalescence than the laparotomy. But in most of our cases, we do the laparotomy. We can perform a salpingectomy where we remove the tube. So you can perform a partial salpingectomy where we remove part of the tube, and this may actually cause future ectopic pregnancies. Or we can perform a complete salpingectomy where we remove the whole tube. We can sometimes perform a salpingostomy where an incision on the antimesenteric portion of the tube can be made. Then this is used for the unruptured distal ectopic pregnancies. So this allows the pregnancy to be removed whilst you spare most of the tube. Then of course you should follow this patient up with beta HCG down to 0, as some pregnancy tissues can actually be left behind and may continue to grow with what we refer to as a chronic ectopic pregnancy. So here's our management algorithm that's going to be used to test for suspected ectopic pregnancy. So this would be a female with a positive urine beta HCG level, low abdominal pain, and or vaginal bleeding. So you do a history and physical examination to determine whether they are hemodynamically stable or hemodynamically unstable. If they're hemodynamically unstable, we can make a presumptive diagnosis of a ruptured ectopic pregnancy or hemorrhage, so we can order for immediate surgical consult or immediate surgical treatment. If they're hemodynamically stable, you want to perform a transvaginal ultrasound, which may either find an intrauterine pregnancy, it may be non-diagnostic, then you may sometimes find an ectopic pregnancy. That's a yolk sac or fetal pole or cardiac activity that you note outside the uterine cavity. So you're going to treat them as an ectopic pregnancy. And of course, if it's non-diagnostic, we use quantitative serum beta HCG levels. If the beta HCG levels are greater than 1,500 milli-international units per mil or 1,500 international units per liter, then if there's a suspicious mass in the adnexae, then you can actually perform a medical or surgical treatment for ectopic pregnancy. If there's no adnexal mass, there's no intrauterine sac, then we repeat the beta HCG and the transvaginal ultrasound in about 2 days, which may show an intrauterine pregnancy or it may not show an intrauterine pregnancy. If it doesn't show an intrauterine pregnancy, then the HCG levels is increasing or plateauing, we treat them for an ectopic pregnancy. If the HCG levels are decreasing, then this is a failed pregnancy, whether it's an intrauterine or ectopic pregnancy. So we continue with our weekly beta HCG until it becomes negative. Then of course, if our HCG levels are less than 1,500 milli-international units per mil, we repeat this beta HCG levels in 72 hours. If the HCG levels are plateauing or suboptimal rise and it's less than double, then we do a transvaginal ultrasound. If you may find an intrauterine pregnancy, you may find a mass in the adnexae, you treat this as an ectopic pregnancy. If it's a negative transvaginal ultrasound, then this is going to be an ectopic pregnancy or failed intrauterine pregnancy. We treat them medically or surgically. If the HCG doubles after 72 hours, then we follow them up with transvaginal ultrasound until the intrauterine pregnancy or the ectopic pregnancy is demonstrated. If the HCG levels are falling, then this is a failed pregnancy, or which may be either an intrauterine or an ectopic pregnancy. We do our weekly beta HCG until it comes back negative. The prognosis is going to be, of course, dependent. Recurrence rates of ectopic pregnancy are going to be depending on the reason why this ectopic pregnancy was actually present in the first place. So this is usually quoted is that the risk of pregnancy after surgery is approximately about 5 to 15%, depending on whether the management is laparoscopic or it's an open laparotomy. Some patients will not wish for further conception after an ectopic pregnancy, but for those that do, approximately 50% of them achieve a live birth. Coming back to our warm-up question, Ectopic pregnancy has a higher incidence in women with copper intrauterine devices. That's false. B, cannot be diagnosed by ultrasound. That's false. It can. C, is treated by laparoscopic salpingostomy. It can be. D, is excluded by a negative serum beta HCG. That is true. If you don't have beta HCG, most likely this person doesn't have an ectopic pregnancy. E, has a recurrence rate of 15% after conservative treatment. That is true. I really hope you enjoyed this video on ectopic pregnancy. If you did, consider subscribing to the channel. Hit the bell notification icon to receive notifications of such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.